Yeah, Dr. Divya, please start.
Okay, good evening, everyone. I'm Dr. Divya John Steffi. I'm an MD pharmacologist. So today I'll be talking exclusively on general pharmacology based on the inputs from the last 5-year question papers. Okay, so we will stick to the plan, right? So without much wait, we'll just start. So why general pharmacology is one target area for most of the competitive exams is that you can ask a lot of concept application as well as tie in a lot of systemic examples. So this part is the most extensively tested. So we'll be focusing on the key areas alone, right? So the first question that we'll be seeing today is bioavailability of drugs given via intravenous route is taken as 100%, but exception to this assumption is observed with which of the following agent when given as an intravenous route. Okay, so bioavailability of drug given via intravenous route is 100%. That is standard. So, but exception to this rule is seen with which of the following agent. So the options given are ampicillin, chloramphenicol succinate, dinoprostone, and morphine. So we'll look into each option. Okay. So bioavailability of intravenous formulation of a drug in active form is 100% by general dictum. It is not just any drug as IV, it gets 100%. It is the active drug that gets 100% bioavailability when injected IV. So prodrugs or drugs inactivated in the lung following IV administration results in lowering of bioavailability by IV route. So that is the key concept here. So when we look at the options, ampicillin is an active drug and morphine is active per se, and it's glucuronide conjugate, it's also active. So this will not be a prodrug concept. It is active, right? So it will not fit into the answer key. And dinoprostone is a synthetic prostaglandin E2 analog. So this is resistant to the enzymatic degradation in the lung, in contrast to naturally occurring prostaglandins. So if we were to give a naturally occurring prostaglandin PGE2 analog via IV, it will be inactivated in the lung. So its bioavailability will become 0. So the other option that is left in the question thread is your chloramphenicol. So chloramphenicol succinate is a prodrug, which has to get hydrolyzed to yield free chloramphenicol. So obviously, the answer to this question is the bioavailability of a prodrug chloramphenicol succinate will be low even when it's given IV because it needs prodrug cleavage to give the active moiety that is chloramphenicol. Okay, so that is the first question for today. So the concept is for a prodrug, it has to become active to become bioavailable for the system to take it. So the definition for bioavailability has to be recalled at this point, right? The rate and fraction or extent of absorption of a drug in its active form for systemic use that will be translated as the response, right? Fine. So the next question is, in plasma concentration type curve for a drug following first order kinetics, the absorption rate constant is calculated based on which of the following parameters? So the options are T half, volume of distribution, CPSS is nothing but steady state plasma concentration, CL or clearance. So they're asking what is the relationship between an absorption rate constant of first order kinetics to the 4 parameters. Okay. So we know that absorption rate constant is calculated using the given formula. It is taken from the slope of the curve. So absorption constant is natural log 2 0.693 divided by the T half of absorption. So it is related to the T half. Okay, no other factors involved. So half-life, the other point that this question will tell you is half-life of a drug is the best predictor for drug accumulation or absorption in the body. And half-life of a drug remains constant across varying body sizes because it is a ratio of clearance and volume of distribution. So across varying body sizes also, the half-life is going to stick to a constant, or it is going to be the same. Okay. So the answer to this question, you should not have any doubt. In plasma concentration time curve for a drug following first order kinetics, the absorption rate constant is related to the T half. Okay. Third question in one of the pharmacokinetic parameters is your volume of distribution. Okay. So a low volume of distribution, AVD, is nothing but apparent volume of distribution, indicates which of the following. So does a low volume of distribution mean the drug is abundant in the extravascular tissue? Or does it mean the drug is highly plasma protein bound? Or is the drug sequestered in organs? Or is the person in a disease state like a congestive heart failure, uremia, or cirrhosis? So what does a low volume of distribution necessarily mean? So we'll look into the concept of volume of distribution. So volume of distribution is a theoretic concept that estimates the apparent volume available in the body to accommodate the drug based on how much the given dose is found in systemic circulation, assuming the body fluid compartment to be homogeneous. Okay. So in a single homogeneous compartment model, volume of distribution will be essentially the dose administered divided by the plasma concentration that is available to accommodate it. Okay, so volume of distribution is nothing but dose divided by plasma concentration. So however, in the real life scenario, it is not a homogeneous system. So your apparent volume of distribution is governed by various factors like the lipophilic nature, the ionization constant or pKa value of the drug, degree of plasma protein binding that is available, the fat or lean mass ratio, disease conditions, that is the available plasma concentration and the protein content that can bind and accommodate to the drug. So that will include conditions like congestive heart failure, renal dysfunction, cirrhosis of liver, thyroid diseases, etc. A drug extensively bound to plasma protein is restricted within the vascular compartment and will have a low volume of distribution. So that is the key point. So once the drug is avidly bound to the plasma protein, it cannot come out of the vascular compartment. It is congested within that traffic. Okay, so it will have a low volume of distribution. In other words, it will not be homogeneously distributed across the system. Okay, so a low volume of distribution will now mean that the drug is highly plasma protein bound. Okay, you should not have any doubt with regards to this. Okay, so now we'll look into drugs with high volume of distribution. So wide distribution means the drug will not be amenable to dialysis elimination, or dialysis will be ineffective in instance of toxicity. And drugs with high volume of distribution, we have select few drugs, and I remember it as OABCD because in toxicology, in tox syndromes, we try to revive the patient based on the ABCD or CAB, right? So I remember this mnemonic as OABCD, which is nothing but opioids, amphetamines, benzodiazepines and beta blockers, chloroquines and calcium channel blockers for C, and digoxin. So these drugs have high volume of distribution, and the elimination by dialysis will be ineffective or will be very laborious. Okay. Next question is, first pass metabolism is bypassed by all the following routes of administration except. Okay, so this is one of the easiest questions anybody will answer. So the answer to this question is simple. The first pass metabolism, otherwise called as pre-systemic elimination, refers to metabolism or elimination of the drug during its transit through the gut, liver, and portal circulation before it reaches the systemic circulation. This phenomenon limits the bioavailability of the drug. Certain routes bypass the drug away from the sites of pre-systemic elimination. Liver is one of the major sites for pre-systemic elimination. So certain routes will bypass this, and this will improve the active fraction that is available after systemic dosing. Okay, or it will improve the bioavailability. So we'll check one option after the other. So for instance, drugs given via intravenous route reach the systemic circulation directly. So with no first pass metabolism, so they will have 100% bioavailability, provided they are active drugs. Oral route is the most subject to pre-systemic elimination. Hence, bioavailability of orally administered drugs is highly variable. When drugs are given via sublingual, parenteral, pulmonary, or transdermal routes, they bypass pre-systemic elimination. When a drug is given via rectal route, there is 50-50 chance. Okay, so the fraction absorbed via the internal hemorrhoid vein undergoes liver metabolism, while the fraction absorbed via the external hemorrhoidal vein bypasses the liver. and is free of first pass metabolism. Okay, so this is the concept. So the first pass metabolism is bypassed by all of the following routes except oral. Okay, oral is one that is subject to extensive first pass or pre-systemic elimination. The next question is high plasma protein binding of drug results in. So what does high plasma protein binding of a drug results in? Does it alter or does it decrease glomerular filtration? Option B is high volume of distribution. Option C is it lowers the duration of action. Option D, it has less drug interaction. Okay, so plasma protein binding is one of the important sites of drug interaction. Okay, so there will be a lot of questions that can be asked. So we can take in a lot of systemic examples and ask you questions. So a lot of you can be asked on this. So once the concept is clear, n number of questions asked n number of ways can be answered with clarity. Okay, so most drugs bind to plasma protein in a reversible fashion without translating into pharmacological response. So the plasma protein are called as acceptor sites, or otherwise they are also called as silent receptors, because the protein bound drug is not available for systemic action. The plasma protein will act as a vault or a reservoir or an acceptor site for this drug. Okay, so acidic drugs bind to albumin. Basic drugs will bind to alpha-1 acid glycoprotein. Binding of the drug to the plasma protein affects the pharmacokinetic handling of the drug by the body. So we look into what are all the effects of plasma protein binding on the pharmacokinetics. So once we've already seen this concept, small volume of distribution. So plasma protein bound drugs are largely restricted to the intravascular compartment. They cannot spread further. So they have a small volume of distribution. And they're highly amenable for dialysis related removal, but I'll tell you why it is not possible. Okay, so long duration of action. Bound fraction of drugs act as reservoir for the drug storage in the body, and it is unavailable for so it is unavailable for metabolism or excretion. So unless actively extracted by the liver or the renal tubules. So this bound fraction is in a state of equilibrium with the active free fraction of the drug. So whenever the concentration of the free fraction of drug falls, the temporary drug stores or the acceptor sites will spill the drug that is bound to the plasma protein. So they will have an extended duration of action. With regards to drug interaction, the plasma protein bound drugs are susceptible to displacement reaction. So if a drug with a high plasma protein affinity comes, it will displace a drug with a lower affinity to that particular plasma protein. And renal excretion, plasma protein binding retards glomerular filtration because they are bulky molecules. They will not be filtered through the pore spaces. Okay, and tubular secretion is an active carrier mediated process. So this action is independent of plasma protein bound state of the drug. So if they have a active carrier transporter for a particular drug, then it will be transported across the tubules by tubular secretion. And tubular reabsorption is a passive diffusion. It depends solely on the urinary pH, lipid solubility, and ionization constant of the drug. Okay, so plasma protein binding will result in a decrease or a small volume of distribution of the drug. It will extend the duration of action, and the acceptor site will act as a reservoir whenever the concentration of the active free drug falls. The duration of action will be extended by spillover of the temporary stores of the drug in the plasma protein. Okay, and plasma protein bound drugs are subject to drug-drug interaction via the displacement reaction. Okay, and on renal excretion, there are three processes. The effect on the three processes is that generally by glomerular filtration, unionized small molecular weight non-plasma protein bound drugs are freely filtered. So that is why a plasma protein bound drug, unless it is displaced from the plasma protein binding site, it cannot be dialyzed out. Okay, and rate of filtration is driven by the renal blood flow. Okay, depending on the renal blood flow, this glomerular filtration is progresses. Next is your tubular secretion. So tubular secretion, I've already told you, it is an active carrier-mediated process. It is an important process for elimination of drugs extracted by the tubules, okay, from the plasma protein binding. So two independent saturable systems operant for acidic and basic drugs are your notable OAT, or organic anion transport protein, and your OCT, or your organic cation transporter. Okay. Next is your tubular reabsorption. So in tubular reabsorption, it is a passive diffusion process. It is dependent on the pH of the urine, the lipid solubility, and the ionization constant of the given drug. Okay, so that is the effect of plasma protein binding on the various pharmacokinetic parameters. Okay, so now you know that high plasma protein binding of a drug results in decrease in the glomerular filtration because it is a bulky molecule. It is not amenable to filtration through the into the Bowman space. Okay. Next, coming to the biotransformation. So you already know, all of you will be very familiar with phase 1 and phase 2 reaction. So phase 1 reaction, you have oxidation, reduction, cyclization, hydroxylation, hydrolysis, and decyclization. Okay, so these will essentially open up the functional moieties so that the xenobiotic or a drug which is given as a foreign material will be conjugated by phase 2, a non-synthetic reaction, or conjugation reactions either with glucuronide or glutathione or glycine or sulfate. And the other two reactions that form under the purview of phase 2 reaction will be your acetylation and methylation. Okay, so this is the overview or a bird's eye view of your biotransformation process. So based on this, what all questions can you ask is, as per the new format of questioning, can be asked as identify the reaction which is not a functionalization reaction or a phase 1 reaction. So it could be, options could be like oxidation, methylation, reduction, glucuronide conjugation. So because you're already introduced to the topic, now you will know that your methylation and glucuronide conjugation are phase 2 reaction. So don't get confused by the name of the reaction. Acetylation and methylation falls under the purview of phase 2 reaction. Okay, all phase 1 reactions and glucuronide conjugation takes place in the cytochrome P450 or your microsomal site. Okay, so that is also one of the key questioning areas that they do. Okay. The next question is a clinical application form of question of the same concept. So in Crigler-Najjar syndrome, the metabolism of which of the following agent is deranged? Okay, and the options given are diazepam, dapsone, steroids, and methyl dopa. Okay, so in Crigler-Najjar syndrome, the metabolism of which following agent is deranged? So in Crigler-Najjar syndrome, which is a rare genetic disorder where you have UGT1A1 expression deficit. So you have abnormalities or deficiencies in the liver function, especially glucuronide conjugation. So one of the primary drugs that is biotransformed by glucuronide conjugation is your diazepam. So in Crigler-Najjar syndrome, the metabolism of diazepam is deranged. Okay, so you should be able to identify this. Okay, so only phase 2 reaction taking place in endoplasmic reticulum via microsomal enzymes is your glucuronide conjugation. And glucuronide conjugation is deficient in Crigler-Najjar. Drugs metabolized by glucuronide conjugation, the list is your benzodiazepines. Example that was given in this question was diazepam, statins, estrogen hormone, irinotecan, and atazanavir. So all these drugs are metabolized by glucuronide conjugation. So in a condition which compensates or which makes the glucuronide conjugation deficient, all these drugs metabolism will be affected. Okay. Next is your clopidogrel omeprazole interaction. So this is common clinical utility question 2. So what is the site of interaction, or which is the site that produces drug interaction between clopidogrel and omeprazole? So the cytochrome enzyme that is involved in the metabolism of these two substrates will be or CYP2C19. Okay, so omeprazole inhibits the oxidation of certain drugs like diazepam, phenytoin, warfarin levels may be increased, and it also interferes with the activation of clopidogrel by inhibiting CYP2C19. Okay, So the site of interaction between clopidogrel and omeprazole should be CYP2C19. Okay. So just a bird's eye view about the cytochrome enzymes that are of clinical importance or that could be potentially asked is your CYP3A4 metabolizes most of the 90 to 95% of most of the drugs is via the CYP3A4. So you have family at 3, subfamily A, and 4 is the gene which codes this enzyme. Okay, so CYP3A4. Next you have CYP2D6. Okay, so CYP2D6 is the next important cytochrome enzyme or microsomal enzyme. So it is involved in the metabolism of most of the psychiatry or CNS drugs, codeine and beta blockers except propranolol. So this might be one of the question threads for your exam. Okay, so which beta blocker is not metabolized by CYP2D6? The answer would be propranolol. Okay, and codeine sensitivity of a patient might be determined by the which cytochrome isoenzyme, then you will have to write CYP2D6. Okay. Next, you have to CYP2C9. Okay. CYP2C9 is important in the metabolism of phenytoin and warfarin. It is one of the important pharmacogenetic variables that has been documented in the package insert, or the person has to be subjected to testing. Whenever they are put on warfarin, they will look at CYP2C9 pharmacogenetic profile as well. Okay, so that is an important pointer. Then you have CYP2C19, and the drugs that are metabolized are your proton pump inhibitors, clopidogrel, and propranolol. So that is why in a patient who is on clopidogrel, it is not scientific or it is not rational to prescribe a proton pump inhibitor because the drug interaction is possible at CYP2C19. Okay. So this is like a easy recall for your enzyme inducers and inhibitors. So this is the mnemonic that I use. The age-old mnemonic is what I use. So each one of you can devise your own mnemonics, whichever is easy for you, but make sure that you are sticking to one, okay? And don't be voracious in, like reading only the mnemonics. It might not help, okay? So stick to one simple mnemonic. So GPRS cell phone is what I remember my inducers as. So you have griseofulvin, phenytoin, rifampicin, smoking, carbamazepine, and phenobarbital. So this list are the drugs which will act as enzyme inducers. Okay. And for enzyme inhibitors, microsomal enzyme inhibitors, I remember it as sickfaces.com. So you have sodium valproate, isoniazid, cimetidine, ketoconazole, fluconazole, alcohol, chloramphenicol, erythromycin, sulfonamides, ciprofloxacin, omeprazole, and metronidazole. So this is one way of remembering, or you can clinically correlate and read as well as how we did omeprazole, clopidogrel. You can also try to do with that. Okay. So the next question is loading dose. Okay. So loading dose of a drug is governed primarily by. So this is one of the key areas that are repeatedly asked. Okay. So loading dose of a drug is governed primarily by. So is it dependent on the clearance, volume of distribution, plasma half-life, or elimination coefficient? Okay. So you know that loading dose is a single high dose or few quickly repeated doses given at the beginning of drug therapy to attain the target plasma concentration. And that is the definition for your loading dose. So loading dose has to be given in repeated doses or at high doses. And it will ultimately depend on the target plasma concentration that you are trying to reach, the volume of distribution that is available to accommodate the given dose, divided by bioavailability. In case it is an IV given drug, this bioavailability is 100% or at the max 1. So a loading dose of a drug given via IV, the equation becomes as target plasma concentration into volume of distribution. Okay. So hence loading dose is primarily governed by the volume that is available to accommodate the given dose. So volume of distribution, and it is independent of the plasma half-life or clearance. Okay. And on the other hand, your maintenance dose is a function of your clearance, and plasma half-life, because you're trying to maintain that plasma concentration when the level is fading off from the systemic circulation of plasma concentration as a result of elimination or clearance, or the fall in the T half, or like the progress of dosing duration. Okay. So loading dose is a function of volume of distribution. Okay. So there are multiple possible questions that can happen, and one such is your calculations. So they'll give you data and ask you to calculate loading dose with a given data for administering a drug X in a given clinical condition. So for giving a loading dose via IV, the equation is very easy. So loading dose is volume of distribution into desired plasma concentration. For an oral route, you will always have to divide it by the bioavailability. Okay. For a maintenance dose, to maintain plasma concentration after a certain period of time, this accounts to the loss of drug by elimination or clearance, and it is a function of clearance as well as T half. So how do you calculate maintenance doses? Maintenance dose by IV is nothing but the clearance into plasma concentration and the time duration in hours. Maintenance dose by IV will be nothing but divided by bioavailability of that drug. This is maintenance dose by oral. Okay, so maintenance dose by oral, sorry for the mistake, maintenance dose by oral will be the same equation divided by bioavailability. Okay, right. The next question is, therapeutic drug monitoring is not scientific for which of the following agents? Okay, so now we are talking about plasma concentration, right? The next concept that we'll be testing in general pharmacology is about therapeutic drug monitoring. So among this option, ticlopidin, theophylline, tacrolimus, and warfarin, which do you think is not rational to do a TDM, a therapeutic drug monitoring? Okay, so the answer is ticlopidin. Okay, why ticlopidin? Is because therapeutic drug monitoring is not scientific when an agent of interest is a hit and run drug. Okay, and ticlopidin is example of a hit and run drug. The action of the drug will persist in the absence of detectable plasma concentration. So your therapeutic drug monitoring is ineffective at this point. Okay. So the other examples of hit and run drugs are your monoamine oxidase inhibitors, indirectly acting sympathomimetics like reserpine, guanethidine. Then you have proton pump inhibitors and aspirin. So all of them can act as hit and run drugs. Okay. Next is drugs showing optimal efficacy only within a bracket of plasma concentration range with loss or no efficacy below or above the specific range includes all the following except. So this is nothing but your therapeutic window phenomenon, right? So drug showing optimal efficacy only within a bracket of plasma concentration with loss or no efficacy below or above the specific range. So that is the definition for a drug following therapeutic window phenomenon. Okay, and they've asked the choices as imiprimin, clonidine, glipizide, and digoxin. Okay, so you already know the answer. Digoxin, right? So drugs showing therapeutic window phenomenon include tricyclic antidepressants like imiprimin, centrally acting sympatholytic antihypertensive like clonidine, and oral hypoglycemic like glipizide. Only these three drugs are recorded in the textbook as drugs showing therapeutic window phenomenon. Okay, and digoxin is a low safety margin drug with narrow therapeutic index. Okay, so the next question that we'll be seeing is, okay, looks very complex, but it is probably the most simplest of questions. Okay, so in the following log dose response curves, curve A and B denote the type of drug receptor interaction. Identify the type and choose the best possible example for A and B type of drug receptor interactions from the given choices. So you will have to see for the log dose response curve, and drug A has affinity, but it is raising the direction of the, or it is increasing the efficacy to a submaximal level, right? So agent with affinity but submaximal or half maximal intrinsic activity is nothing but a partial agonist. So drug A is a partial agonist, and a drug B is making a inverse, or it is taking the reaction to an opposite direction, right? So that is a inverse agonist. Okay, so you are trying to identify a partial agonist and an inverse agonist. Okay, so from the given options, these are what we have to do. Okay, So over here, you are given options: tamoxifen, atropine, pentazocine, chlorpheniramine again, pentazocine again, then naloxone and DMCM. Okay. So now we'll analyze option by option. Okay. The answer to this question is pentazocine on mu receptors and chlorpheniramine on H1 receptors. So how do we do this is, among the cited option, the classic example of partial agonism is your pentazocine on the mu opioid receptor, and for inverse agonism it is chlorpheniramine on H1 histaminergic receptors and DMCM on the benzodiazepine receptors. Now we will have to fit it to the correct options, right? The other examples that were given were your tamoxifen. So tamoxifen is a selective estrogen receptor modulator which acts as a pure antagonist at the estrogen receptors alpha in the breast carcinoma cells and partial agonist at the uterus, bone, liver, and pituitary. Atropine is a competitive antagonist at M3 receptors, muscarinic receptors. Naloxone is a pure mu opioid antagonist. So once you identify or once you know that a partial agonist is pentazocine, you will stick to that and you will check option for the others. So pentazocine, mu opioid receptors. So this is probably the correct answer. So this is one way that the examiner will try to stun you, but it is a very simple concept, right? So that is how you crack this. Okay. Next is variation in drug responsiveness to a particular dose of a drug in different individuals can be obtained from. So over here we were seeing with different drugs and response, right? Over here, different responses of the same drug in the given same dose in different patient or different individuals. Okay, so they're asking about graded dose response curve, efficacy, potency, quantile dose response curve. Okay, so the question is, variation in drug responsiveness to a particular dose of the drug in different individuals can be obtained from which of the following. Okay. So drug response to the same drug used in same doses in a population varies based on many factors governing pharmacodynamics, okay, and also pharmacokinetic handling in that particular population. So it can be age, genetics, comorbid condition, concomitant medication, and so on. Okay, so this pharmacodynamic variability in a population can be analyzed by using quantile dose response curve. Okay, so quantile dose response relationship is a all or none plot traced based on response elicited to varying doses of drug administered to a population. So simplified example to understand this is, suppose say a hypnotic agent is being tested to determine the safe dose range for use in general population. A sample size of 100 individuals is selected from the general population to determine the safe dose range. Okay, so these 100 individuals have differences in sensitivity to the drug due to variability in their pharmacokinetics and dynamics. So the test drug is given starting from a low dose and gradually escalating to the maximum tolerable doses. So one dose after the other to all 100 individuals, and the dose eliciting response in each dose set of all the 100 patients is collected. Okay, so with each dose set you have 100 observations. Okay, so hypnosis produced by each dose set in all the 100 subjects is extrapolated into a cumulated frequency distribution on log scale. Okay, an intercept is taken in the plotted graph at the hypnotic dose where it produces 50% of the subjects or population to fall asleep. So that is nothing but your effective dose 50 for a given drug. Okay, so this now will look very easy to understand, right? So we've taken ED50 by collecting that intercept of the curve which shows where 50% of the subjects have fallen asleep after a test dose, after the testing hypnotic has been given. Okay, and the maximum tolerable dose, or something that the person does not can tolerate to a certain extent, that can be taken as the LD50. So this gap between the ED50 and the LD50 will determine the safety margin or the therapeutic index for the drug. Okay, easy, right? So variation in drug responsiveness to a particular dose of the drug in different individuals can be obtained from your quantile dose response curve. Okay, so this is hand in hand, like what you do for therapeutic index in animals. We do a median lethal dose by median effective dose. That cannot be done in humans, so we do a quantile dose response curve. Okay, the next thing is your Which of the following drug which of the drugs shown depicted below in the graph shows high potency? Okay, so you have three drugs, drug A, B, and drug C. Okay, and they're asking you which has high potency. Okay, so in the given relation, log dose response curve, in the relative log dose response curve of three drugs A, B, C, drug A is the most potent, okay, because a small dose can produce the response, okay, so it is a potent drug, right? And position of DRC in the dose axis, x-axis, will depict the potency of the drug. The peak or the height of the DRC tracing will, along the y-axis, will show the efficacy of the drug, okay. So what is the difference between potency and efficacy? So the amount of drug needed to produce a certain response is potency, and it is traced along the x-axis. And relative potency of two drugs can be compared. And when the shift of the potency to the right happens, or something like A gets shifted to B, then it means more dose of the drug is required to elicit the certain response, or the drug is losing its potency. Okay. And shift of potency to the left is lesser dose elicits response, or the drug has better potency. Okay. And potency helps to determine the dose of drug that is required in a person. Okay. Next, coming to the concept of efficacy. Efficacy means maximal response that can be elicited by a drug. Okay. It is traced along the y-axis or the response axis. Relative efficacy between two drugs can be compared. So spurting of height, okay, or increase or augmentation of the height of DRC along the y-axis shows higher efficacy of the drug. Stunting of the height or shortening or flattening of the height of the DRC shows the lower efficacy of the drug. Okay, efficacy is a decisive factor for choosing the drug. Okay. So now you know for sure that drug A is highly potent, drug B and C has comparable potencies, and highly effective you cannot say because they are almost the same heights. Okay. Next is your therapeutic index. So therapeutic index, by definition, it means it is the safety margin of the drug. So you should not have any doubts with this. So this is already done concept, right? Right. So in animal studies, I was telling you, your therapeutic index is calculated as median lethal dose by median effective dose. Okay. So I'll go back again. So median effective dose, or the denominator, should be small in comparison to the median lethal dose for the therapeutic index to be high, or for the drug to be safe. Okay. So if I have a drug whose median lethal dose is 10 and the median effective dose is 5, even a twofold increase will make that drug toxic to the human or animal that we are using. But suppose say the median lethal dose is 1000 and the median effective dose is 10, then I will have to increase the dose 100 times to make a safe drug poisonous. So that is the safety margin of the drug. Okay, so that is therapeutic index. Okay, right. Next concept that we'll be seeing is your suicide inhibition. Okay, so suicide inhibition is seen with all the following agents except. Okay, and the options given are exemestane, clavulanic acid, eflornithine, and anastrozole. Okay, so now we'll see what is suicide inhibition. Okay, so suicide inhibition or suicide inactivation, or it's otherwise called as mechanism-based inhibition, is an irreversible form of enzyme inhibition. Okay, that occurs when the enzyme binds to a substrate analog and forms an irreversible complex with it through covalent bond. Okay, and this happens during the sequence of the normal catalysis reaction. Okay, this inhibitor binds to the active site where it is modified by the enzyme to produce a reactive group that reacts irreversibly to form a stable inhibitor enzyme complex. Okay, I'll make it very simple or very easy. Okay. So inhibitor is structurally analogous to the substrate. It binds to the active site of the enzyme. The chemical reaction is catalyzed in the presence of the inhibitor. A dead-end complex without generation of intended product of the catalytic reaction due to the covalent binding of the inhibitor to the enzyme happens. Okay. So by its own reaction, by its own intended reaction in the presence of inhibitor, it is forming a substrate, and that substrate is committing suicide on the enzyme. It is not making the enzyme to progress further. That is why it is called as mechanism-based inhibition or suicide inactivation or suicide inhibition. Okay, so the enzyme is inactivated because of its own catalytic reaction. Okay, and the examples of suicide inhibitors, you have eflornithine for ornithine decarboxylase, clavulanic acid or beta-lactamase inhibitors for beta-lactamase, steroidal agents like formycin, exemestane for aromatase enzyme, non-selective monoamine oxidase inhibitors like phenylazine, isocarboxazid, phenylcyclopyrin, cypromin, which acts as suicide inhibitor for monoamine oxidase. So this is the list of suicide inhibitors present. Okay. Right. So now you know suicide inhibition is seen with all the following agents except anastrozole. Okay. Okay. So one of the questions that is repeatedly asked is your non-competitive enzyme inhibition is characterized by alteration of what all parameters, right? So non-competitive enzyme inhibition of the drug is characterized by option A, increase in Km or decrease in the Vmax. Okay. Decrease in Km or increase in Vmax, decrease Km or decrease Vmax, Km is unchanged and decrease in Vmax. Okay. So in non-competitive inhibition, drugs bind to the adjacent site and not the catalytic site in an irreversible fashion, resulting in the alteration of the enzyme, making it lose its catalytic property. So this is different from the suicide inhibition, right? So Km remains unchanged and Vmax reduces in the non-competitive antagonism. Classical examples of your non-competitive enzymatic inhibition or antagonism is astazolamide on the carbonic anhydrase, theophylline on phosphodiesterase, efavirenz on reverse transcriptase. Okay. So this is your graph which clearly shows, or which is very easy to recall during exams. Okay. So we plot the substrate concentration along the x-axis and the reaction velocity, which is the estimated parameter here. So that is along the y-axis. Okay. So normally the enzymatic reaction will carry along the normal curve. Okay. So this is the Km and Vmax for it. Okay. So Km is nothing but the rate constant of the reaction and Vmax is nothing but the maximum velocity of the reaction. So in the presence of, if there is a substrate, if there is a drug or agent that stimulates the enzyme, then what happens is the Km decreases, the rate constant of the reaction decreases, but the Vmax is augmented. Okay, so it rises steeply. Okay, in the induction, the Km may not change much, but the Vmax increases. Okay, this is the normal curve. With induction, there is increase in the Vmax, but not much of change in Km. Whereas with enzyme stimulation, the Km is decreased and the Vmax is doubly augmented. Okay, with competitive inhibition, what happens is your Km increases and there's not much of change in Vmax. Okay, in non-competitive inhibition, that is the question for that is the question that was asked. There is no change in the rate constant of reaction. However, there is a decrease in the Vmax or velocity of reaction. Okay, so that is the answer to this question. Okay, now this is one favorite area of questioning in most of the competitive exams. Okay, so they will ask what is the type of receptor for this agonist or this antagonist or for this drug. Okay, so this is one flashcard maybe that you will have to remember and recall. Okay, so we know that receptors are basically classified as ion channel receptors, G protein coupled receptors, transmembrane receptors, which could be tyrosine kinase kind of receptors or JAK-STAT binding receptors, and you have nuclear receptors. Okay, so we'll quickly revise the salient features of each of the receptors. Okay, so the ion channel receptors are the simplest type of receptors which are membrane bound, and the effector is the receptor per se. It is the ion channel which is permitting and causing the biological response. So they are the rapidly acting or millisecond wise acting receptors. Okay, so rapidly acting or instantaneous action can be produced by drugs that act via ion channel receptors. Okay, and structure is, it is an oligomeric assembly of subunits around a central pore, and that central pore will transmit cations or anions, okay, and that will result in the response, okay. The examples or classical example for ion channel related receptors are your nicotinic receptors, cholinergic receptors, GABA A type of receptors. So GABA A type of receptors are ion channel receptors, glycine, both of them are chloride channels, glutamate, and 5-HT3. Which among the following 5-HT receptors are ion channel? Then it becomes 5-HT3. All the other 5-HT receptors are G-protein coupled receptors. So that is the key to note. Okay. Then you have GPCR receptors. So extensive area of research has been done in GPCR. So GPCR receptors are again membrane-bound receptors. They can activate a secondary messenger system, which can be an ion channel or an enzyme. So they are categorized into GS, GI, G0, GQ, and so forth. Okay. And the action takes seconds to minutes, and the structure is characteristic. They have 7 alpha helical transmembrane spanning hydrophobic amino acids with 3 intracellular and 3 extracellular loops. Okay, so they are septahelical, and otherwise they are transmembrane, otherwise they are serpentine. Okay, so all these are keywords to note. Then you have examples for your GPCR. So most of the examples will fall under this. Okay, so your muscarinic receptors M1, M2, M3, dopamine D1, D2 receptors, adrenergic receptors, GABA B type of receptors are G-protein coupled receptors, 5-HT1 and 2 receptors, prostanoid receptors, histamine H2 receptors, glucagon, then you have LSH, FSH, ACTH, TSH, vasopressin, oxytocin, posterior pituitary hormones, opioids mu delta, adenosine A1 receptors, angiotensin AT1 receptors, bradykinin B2 receptors, A, B, C, okay, cholecystokinin, gastrin receptors, and platelet activating factor. All these are G-protein coupled receptors. A predominant of them fall under G-protein coupled receptors. The next type of receptor is your transmembrane enzyme linked receptors, which are also membrane bound, and they have an effector system which activates protein kinases, okay, and they take hours to act, okay. After signal generation, they take hours to give a response. And they are single transmembrane helical peptide with intracellular enzymatic activity site and an extracellular ligand binding domain. So they can be further divided into 3 types or examples. So receptor can be linked to a tyrosine kinase, and this will your insulin, epithelial growth factor, platelet-derived growth factor, vascular endothelial growth factors related to all these will act via these tyrosine kinase receptors. Okay, so most of this will form the focus, or the monoclonal antibodies are formed against these type of receptors in your targeted chemotherapy. That we'll be seeing in day 4. Okay, so next is your membrane-bound guanylate cyclase, of which natriuretic peptide receptor is a classical example. Then the transmembrane receptor can be linked to a tyrosine phosphatase, and the example is your pleiotrophine and contactins. Okay. Next group of transmembrane receptors that are bound to a specific type of JAK-STAT or Janus kinase signal transducer and activator of transcription system. It takes hours to exhibit its effect. It is again a single transmembrane helical peptide with extracellular ligand binding domain. And the important agents that act via JAK-STAT is your growth hormone, prolactin, and interferons. Okay, and nuclear receptors are intracellularly placed. All the others are membrane bound. Over here, nuclear receptors are intracellularly placed. They involve with gene transcription, which takes hours to days to produce a response because it has to go through transcription, translation, and protein expression, right? And they are classically steroid receptors, and the steroidal hormones, thyroxine, vitamin A and D act via nuclear receptors. Okay, so this is one important flashcard that you will have to remember because there are a lot of questions that have been asked. Okay, so from the given choices, identify an agent that exerts its action through serpentine receptors. So you know serpentine receptors are G-protein coupled receptors. Now we'll look into the options: glucagon, glycine, prolactin, thyroxine. Okay, so you know that glucagon will act via your GPCR. Okay, so flashcard again. So glucagon acts via G-protein coupled receptors. Okay, so identify an example of GPCR receptor from the given options. So you have muscarinic, nicotinic, GABA A, and 5-HT3 receptors. So you know that your nicotinic, GABA A, and 5-HT3 receptors are ion channel receptors. So muscarinic receptors are your G protein coupled receptors. Okay. Next is agents acting via tyrosine kinase receptors. All these three questions have been found intermittently interspersed during the last 5 years of competitive examination. So that important this concept is. Okay. So agents acting via your tyrosine kinase receptor is insulin, glucagon, MSH, transforming growth factor beta. And you know the answer is insulin. Okay. So you know that tyrosine kinase related is with your insulin and other growth factors. Okay. Fine. Now we'll recap again. Identify the false statement regarding the phase. Oh, sorry, we're doing clinical trial for the first time. Sorry. So identify the false statement regarding the phase of clinical trial testing an approved drug for approved indication using the approved dose and route. Okay. So this is a clinical trial of a drug that has been approved and it is out in the market and it is given with an approved indication using the approved dose and route. Okay. And the options for that are no fixed duration for conduct of trial, blinded and comparative trial. Sole purpose is to identify the spectrum of adverse drug reactions, possible drug-drug interactions, and compliance. Involves collection of data from multitudes of general public population with the disease. Okay, so you already know it is an approved drug. So it is once in the market, you already know that the drug is given for that particular purpose and that dose. So it is not essentially a blinded or a comparative trial, right? So that is the answer to this. Okay. So typical characteristics of various phases of trials is important. They keep asking question after question in different ways on this. Okay. So let's just see again. So phase 1, it is first in human trial. Okay. So it is first in human trial, which is usually done in a very small population set. Okay. A testing set is very small, around 10 to 100 participants. And usually it is done in healthy volunteers who are free of the disease. In case we are testing in patients with the disease, it's usually a very rare condition or in persons with an advanced stage of cancer where you think that the drug might be potentially useful. Okay. So in that condition, you can use patients as well. Okay. So first in human is generally done in 10 to 100 healthy volunteers who are devoid of the disease. And it has to be open label. Okay. It has to be open label. There's no blinding. And the primary agenda of your phase 1 trial is to see for the safety and tolerability of the new drug. Okay, so that new drug has to be tested only for the safety and tolerability in the healthy individual. Okay, next is your phase 2. Phase 2 is first in patient trial. So, okay, it is of the phase 1. So, 500 participants. The patients are usually subjects who receive the experimental drug. Okay, so they are testing first time in the patients and they receive the experimental drug in a randomized and controlled fashion. It could be a placebo controlled as well, and blinding may or may not be there depending. Okay, and efficacy and dose ranging is the primary agenda of your phase 2 trials. Okay, in phase 3 trials, which is a multi-site trial, a few hundred and few thousands of patients are involved, and the patients receive the experimental drug in a randomized and controlled fashion. It can be placebo controlled also or uncontrolled as well. It can be or may be blinded. Okay, so this is to confirm the efficacy in the larger population set. Okay, so once you've established efficacy and dose ranging, it is tested as a therapeutic confirmation in phase 3. Okay, and in phase 4, which is otherwise called as post-marketing surveillance, many thousand patients or participants are exposed to the treatment in an open label form. Okay, so the prescriber knows what drug they are giving, the receiver knows that they are getting a new drug, and anything that happens has to be updated periodically for the first 4 years of the new drug. Okay, so what is the primary concern here is your adverse event monitoring, compliance, drug-drug interactions. And in all these phase 3 till phase 3 trial, we have been testing only in a standard testing condition in very stringent inclusion or recruitment criteria. Okay, so adults over this year, adults less than this year. So over here, when you give it out in the market, we are testing it in a wider or interpolating it into a wide public. Okay, with like modification of the inclusion exclusion. Okay, right. So based on this, there are a lot of questions that have been formed. So first in human pharmacology clinical trial aims to identify all the following except Okay, first in human pharmacology is nothing but phase 1 clinical trial, right? So the aim is to identify the pharmacokinetics, efficacy, tolerability, and safety. Okay. So of these options, you know that efficacy is not the primary agenda of phase 1 trial, because we are not testing it in the patient. We are testing it in healthy volunteers. So efficacy or the protective benefit or whatever of the drug is not a parameter that can be done in phase 1 trial. Okay, very simple as that. Okay, so the primary agenda of your phase 1 trial is to see the safety, tolerable dose range, pharmacokinetics, and adverse effects. Efficacy, since the trial is conducted in healthy human volunteers who are free of the disease, the therapeutic efficacy cannot be assessed. As simple as that. Okay, provided it is done in healthy volunteers. If you're talking about an advanced stage disease or a rare disorder, it changes, right? Now, identify the true statement regarding clinical trial. Phase 1 is done to determine efficacy in patients. Healthy volunteers are recruited for the first time in phase 2. Randomized controlled trials in patients is done in phase 3. Phase 4 is a pharmacokinetic study in animals. So this is like one blunderous question that happened. So you know that the answer is C. Okay. So these are all questions that have been asked over and over. Okay. So we'll recollect or recap quickly. So your phase 1 study is otherwise called as first in human pharmacology and safety study, which is done in 10 to 100 population of healthy volunteers, where the investigational new drug is given in an open label form, primarily to check the safety and tolerability of the drug in the healthy population. Okay, and next you can even check for the pharmacokinetics and the adverse drug profile. Okay, safety and adverse drug goes hand in hand. Okay, and then you have phase 2. Phase 2 is first in patient, or it is a therapeutic exploration and dose ranging study, where 50 to 500 or a five-fold of this phase 1 is taken, and patients are introduced to the investigational new drug either in a randomized, always in a randomized, and either with a controlled or a placebo control or uncontrolled form, with or without blinding. And the main aim is to find the efficacy and dose ranging. Phase 3 is multi-site therapeutic confirmation or comparison study, where thousands or a few hundred thousands or hundreds of population is used, where the patients are exposed to the investigational new drug in a randomized control with or without blinding fashion to confirm the efficacy in the larger population. Okay. Phase 4 is post-marketing surveillance or data gathering, okay, where many thousands of patients are exposed to the new drug after market approval, and it is in an open label form. Okay. And the adverse drug events, drug-drug interaction, compliance, how the drug acts in special population, like in the geriatric population or in patients with renal or hepatic dysfunction, all that you can collect by phase 4. And restricted marketing and periodic safety update reports have to be submitted when the drug is introduced in the market as a new drug for the first 4 years after approval. Okay, so it is usually done, PSURs are reported every 6 monthly for the first 2 years and then yearly for the next 2 years. Okay, right. So you have one case scenario here. So this has been introduced recently now. So there has been curricular changes in the MBBS syllabus right now. So one of the exercises that the students have been exposed to since 2019 is your pharmacovigilance or ADR reporting. So one exercise that we will try to do today is based on that. Okay. So you've been given a case, Mrs. Rekha, 27-year-old female who has suffered from herpes zoster. The physician has prescribed her tablet carbamazepine 100 mg BD on 12/1/2020 for her post-herpetic neuralgia. 4 days later, patient developed hyperpigmented macular eruptions with mucous membrane involvement, and she's been diagnosed with Stevens-Johnson syndrome. The drug was stopped immediately, and the same day itself, patient was admitted to the intensive care unit and treated symptomatically. She recovered. Okay. So this is one of the practical exercises that the students are doing in MBBS. Second years are doing this. So assess the causality using WHO scale. What is the causality assessment by Naranjo scale? Assess the severity using Hartwig-Siegel scale. So for a competitive exam, what you will have to know is, for causality assessment, or to say that the drug is the cause for this given adverse effect, we use WHO standardized scale and Naranjo algorithm. Okay, and to see the severity scaling of a given ADR, we use modified Hartwig-Siegel scale. Okay, so this is the thing, or these are 3 questions that could be asked. Okay, so what basically causality means is to say that the drug is the cause for a given adverse drug reaction. Okay, it in this grading, your WHO scale goes. Okay, so it can have a certain causality, probable or likely causality, possible and unlikely. There's another spectrum that is called as unclassifiable or unassessable, where you don't have much of data that is being recorded. Okay, so we'll not look into that. We'll look into workable examples, right? So certain causality means that the drug and the adverse drug reaction has a temporal association, as in after the drug has been given, the person developed an adverse drug reaction after a plausible temporal association. So if I give a drug IV and if there's an immediate hypersensitivity reaction, it is possible. But same drug, the person is naive to that particular drug, you give it as an oral agent and immediately the person collapses. Immediately within 2 minutes if they collapse, it is not possible to be because of the oral drug. Okay, because it takes time for the drug to dissolve, disperse and get into action, right? Okay, so that is temporal association. Next is D-challenge. D-challenge is you take the drug out of the system and the person becomes better, or the adverse drug reaction decreases in its severity, then it is D-challenge. Okay, so if D-challenge is positive, then you know that the the drug in the system is the cause for the reaction. Okay. Next is re-challenge. Okay, so re-challenge test is nothing but you reintroduce the drug again, the person has the similar kind of reaction or exacerbation of the ADR. So that means it is re-challenge positive. Most often patient will not know that they are allergic to a particular drug. They would have taken some prescription and they would have had some adverse drug reaction. They will come later date to get the same treatment from you and they will have an increase or exacerbated course. Okay, so that will give you an idea of re-challenge. Ideally or ethically, it is not how do I say, recommended to give a hypersensitive or a drug that produces an adverse drug reaction to already exposed patient, right? Right. And if you can relate that adverse drug reaction to another disease or to another agent that has been given or to other condition that the patient has, then it will rule out the certainty of causality between the drug and the reaction. Okay, so for a drug to have a certain causal relationship to a particular ADR, it should have a possible or a plausible temporal association. Re-challenge should be positive, re-challenge should be positive, and it should be non-relatable to another disease or any other drug that has been given. Okay, to have a probable or likely causality, it should have 2 out of 4. So temporal association and re-challenge should be positive. Usually re-challenge is not available for certain drugs, or you can the unlikely causal relationship to disease and other agents cannot be established. In those conditions, it becomes probable or likely. Next is possible. So in possible, you only have a temporal association. Everything else is questionable or it is not available. In unlikely, even the temporal association is not there. Okay, so that is how the causality is assessed by using WHO scale. So in this given case scenario, Mrs. Rekha, 27-year-old, has suffered from herpes zoster. The physician had prescribed carbamazepine, and after 4 days, she developed the ADR. Okay, and that is Stevens-Johnson syndrome. So there is a plausible temporal association. So temporal association is there. Drug was stopped immediately on the same day, and patient recovered after ICU treatment with symptomatic medication. So she had a D-challenge positive. So it becomes probable causality. Okay. And your Naranjo algorithm is nothing but a standard set of 10 questions. Okay, each question has, based on the response that you file, it has a weightage. So when you have a score which is over 9 or equal to 9, it means it has definite or certain causality. Okay, when you have a sum total of 5 to 8, it means it has a probable causality. 1 to 4, it is possible, and less than 0, it is doubtful or unlikely. Okay. So I worked it out for this case and it comes to 6, which falls in the range of 5 to 8, which is probable. Okay, so WHO and your Naranjo algorithm matches here. Okay. Next is your severity assessment. Severity assessment, as I told you, it is based on the modified Hartwig-Siegel scale. So what is this Hartwig-Siegel scale is? Level 1 is when an ADR occurred but required no change in the treatment with the suspected drug. Okay, so you can continue giving the drug, which usually a side effect ADR, which is because of the mechanistic action, extension of action. Like when you give an antihistamine, they will have sedation, right? So that is some bearable. You give them a specific advice and ask them to continue the medication, right? So that is level 1. Level 2 is the ADR is required. ADR required the treatment with the suspected drug to be held, discontinued, or otherwise changed. Okay, no antidote or treatment requirement was required. No increase in the length of stay. Okay, so this becomes level 2. Level 3 is the drug required the treatment with the suspected drug to be held, discontinued, or otherwise changed, and or an antidote or other treatment was required. Okay. However, there is no increase in the length of stay in the hospital, or the person does not require confinement. Okay. Level 4 is any level 3 ADR which increases the length of stay even by a day. Okay, it becomes level 4. Or if the ADR becomes the reason that the person got admitted in an institution, it means it is level 4. Level 5 is any level 4 ADR which requires intensive medical care unit. So over here, your Stephen Johnson, she was admitted to the ICU. So it becomes level 5. Level 6 is which produces a permanent harm to the patient. Level 7 is nothing but it resulted in mortality. Okay, so based on this grading, your mild is your level 1 and 2 becomes mild, moderate is your 3 and 4, severe is your 5, 6 and 7. Okay, right. So again, consolidating the concept, for a drug to be coined as probable agent for causing an adverse drug reaction, all the following criteria should be reasonably complied with, except. So plausible, prospective temporal relationship between the drug intake and reaction, no other attributable cause like disease or other drugs to explain the reaction, positive rechallenge, positive dechallenge. So except you will write positive rechallenge. Okay. So how is the ADR communicated to the okay. Identify the interface used for communication of ADR data between these two agencies involved in signal processing. Okay, so for our country, we file it to the National Coordinating Center, which is in IPC Ghaziabad, and this is transmitted to the Uppsala Monitoring Center in Sweden. Okay, so we have a central, we have a national and an international collaborator, and the mode of communication is via which of the following? That is the question. So you have Vigidata, Vigibase, Vigiflow, and Viginet. Okay, so the communication flow that we use is your Vigiflow. Okay, so integrated ADR data is communicated by the Pharmacovigilance Program of India National Coordination Center in Ghaziabad to Uppsala Monitoring Center in Sweden by the Vigiflow interface. Okay, and this is done mainly for picking up signals. And signals are nothing but ADR which occur in high frequency than accepted or documented, or any ADR that happens outside the purview of the known package insert or black box warnings. Okay, so those become signal. Okay, so this was one question that was asked in one of the competitive examinations. Okay, very simple question, but usually when something mathematical gets asked in a exam, we tend to skip it or we make guesses, right? But it is very simple. So a drug solution containing 500 mg per 5 ml of a drug is given to you. You are provided with a 2 ml syringe having 10 divisions for each ml in an injection tray. How many divisions of 2 ml syringe needs to be filled to administer 180 mg of the drug to the patient? Okay. So the options given are 10, 12, 16 and 18. Okay. So concentration of the drug in the given solution is 500 mg in 5 ml. So it is basically 100 mg in an ml. So 100 mg in 1 ml. So if I were to give 180 mg, then it means I have to give them 1.8 ml. Okay. So 1.8 ml of the drug will have 180 mg. In a 2 ml syringe, each ml has 10 divisions. Okay. So each division is 0.1 ml, right? So 1.8 divided by 0.1 is 18 divisions. So the answer is 18. Okay. Very simple. Every time we look at questions like this, we will tend to skip it or we won't work it out. So this is most easy or logical thing to do. Okay. Next question is, the package description of a drug states 500 milligram of paracetamol is present in each unit of the tablet formulation, but in reality, each unit contains only 200 mg. So what is the terminology used for these kind of drugs? Okay. So the options are subtherapeutic drugs, adulterated drugs, spurious drugs, or misbranded drugs. Okay. So instead of 500 mg of paracetamol that is given on the label, they have given only 200 mg. Okay. So this is nothing but an adulterated drug. So any official drug which when tested by the compendial methods fails to conform to compendial standards for quality, strength or purity is adulterated unless the differences from such standards are plainly stated on the drug label. So if I had stated that the drug has only 200 mg of paracetamol on the package instead, then it is safe. Okay. Misbranded drug refers to deficiency in the labeling of a drug. And spurious or counterfeit drugs means any drug with falsity in the proclaimed active pharmaceutical ingredient or proclaimed drug name or manufacturer name or manufactured in guise or substitute of another reputed drug, it becomes a spurious or a counterfeit drug. Okay. And next question will be, which of the following drugs should be sold only on prescription from a registered medical practitioner? So this schedule is Schedule H. Okay. So we look into the other options. Schedule M is manufacturer of prescription medicine. So Schedule M manufacturer. Okay. Schedule M is regarding manufacture of prescription medicine. Schedule H is about prescription medicine by a registered medical practitioner. Schedule J is a disease and ailment which the drug may not purport or claim to prevent or cure. So no drug will be there to cure or abort a particular disease. Okay, so that falls under Schedule J. Okay, Schedule X, as you all know, it is regarding narcotics or drugs or abuse. Okay, right. So which should be done, which of the following drugs should be sold only on a prescription from a registered medical practitioner? You know, it is Schedule H. Okay. So which of the following statement is true regarding fixed dose combination of the drug? Okay. So fixed dose combination of the drug, the options given are adverse effect of one drug may be reduced by the other drug. Two drugs with different pharmacokinetics can be combined easily. Dose of one drug can be altered independently as per requirement. Adverse effect can be ascribed to single agent. Okay. So fixed drug combination is two different drug moieties are combined to a single pharmaceutical formulation. So as a rule, two drugs are ideal for combination as fixed dose only when they are comparable in pharmacokinetics. Okay. So for example, your cotrimoxazole is a combination fixed drug combination of sulfamethoxazole and trimethoprim because their T halves are comparable. Similarly, syndopa is a combination of levodopa and a peripheral decarboxylase inhibitor carbidopa because they have comparable pharmacokinetic T halves. Okay. So what is the advantage of a FTC? So a fixed dose combination essentially improves the patient's compliance. So instead of taking two different tablets, they can all take it as a single tablet with both the moieties together. Okay. Potentiation of therapeutic effects. So combination of two bacteriostatic agents, that is your sulfamethoxazole and trimethoprim, increases the type of activity to bactericidal in your cotrimoxazole. So this is a classic example of sequential blockade. Minimization of side effects. So levodopa dose and the peripheral dopaminergic adverse effects can be reduced when it is combined with a decarboxylase inhibitor like carbidopa and bensericide. Okay. So because you can reduce the dose required of levodopa. Disadvantage is dose of one drug cannot be tailored independently when combined as a FDC. It has to be a fixed dose. Okay. So it rules out the options C given in the question. And two drugs with different pharmacokinetics cannot be combined to obtain acceptable range of plasma drug concentration. So that rules out one another option. Therapeutic efficacy or adversity cannot be pinned to one component. Now you've already seen about the causality. So we are administering both the drugs together at the same time. So you cannot ascribe the ADR to be related to one drug alone in two drugs given together. Okay. So that brings us to the answer of this question. So the adverse drug reaction of one drug may be reduced by the other drug. The classical example that I gave you is your levodopa and carbidopa. Okay. Right. So the next is check the boxes that seem valid regarding bioequivalence. Okay. So bioequivalence means that the drug, two drugs given drugs are pharmaceutically equivalent. They have comparable area under curve with 90% confidence interval limits, 80 to 125% between the two drugs. Bioequivalence studies can be waived off if the test and reference drug is in the form of a solution intended for oral or parenteral infusion, in the same dose or concentration without any additional excipients. So all these three are true regarding bioequivalence. So this is just to introduce you to a new concept. So bioequivalence means that two drugs are pharmaceutically equivalent and they have comparable bioavailability curves or your area under curve with 90% confidence, somewhere between 85 to 125 comparable standards. And the bioequivalence study can be waived off if the test and the reference drug is in the form of a solution or in an oral or parenteral formulation in the same dose concentration without any additional or altered excipients. Okay. Excuse me. Okay. So this is just one. We've been going very fast, right? So I thought we'll have one breather here. So who am I? A drug is inactive as such, needs biotransformation inside the body to form an active drug. Okay, drug per se is inactive, needs biotransformation to become an active drug. So it is nothing but a prodrug. Okay. Next is find my classic pair, classic examples of pharmacological phenomena. So this is one way we can test. So when we try to recall things, we can do this flashcard things, right? So Hoffman elimination, it is characteristic of atracurium. Okay. Elimination by spontaneous rearrangement without an enzymatic agency. Okay. So mixed aura kinetics is by high dose aspirin. Okay. Ion trapping is one principle that we see with aspirin in general. Okay. So it gets trapped inside the gastric mucosal cells and results in gastritis or ulcerations. Tachyphylaxis is a feature of ephedrine and indirectly acting sympathomimetic. Okay. So again, this concept has been time tested. So you know that with drug antagonism, with receptor-based antagonism, a shift of the DRC towards the right means it is a competitive type of antagonism or an equilibrium type of antagonism. Okay. And if there is stunting or if there is a shortening of the height of the DRC, then it means it is a unsurmountable or a non-competitive type of blockade. Okay. So that is something that you all know. Okay. And one of the logical questions that could be asked is liver disease and drug disposition. So when do you not anticipate toxicity? When the drug is metabolized by the liver in the presence of liver disease. Okay. So pro-drug needing hepatic activation. Okay. So over here, you know that the liver disease is there. So the hepatic function is not adequate. So pro-drug may not become active. Okay. So that is one possibility here. Drug metabolized by the liver. So if the drug's action has to be terminated by the liver, if the liver is not acting, the drug will become toxic because it accumulates inside the system. Synthetic function of the liver is affected. So albumin bound drugs will all be free in the circulation, right? So that will result in toxicity. Drugs with negligible first pass metabolism, they don't essentially require the liver to take it away, right? So the ideal or the most probable answer for this is pro-drug needing hepatic activation. Okay. So because this pro-drug is not converted to the active moiety, it might not produce toxicity because pro-drug as such is inactive, right? So another or the last question for today is neonate suspected of sepsis was administered with an IV antibiotic, following which the baby stopped feeding, became lethargic, respiration became erratic, abdomen was distended, ashen gray cyanosis was noticed. This was confirmed as a medical error. Okay, what could be the inciting drug? Okay, so you know that it is an IV antibiotic, and this is the characteristic feature of your gray baby syndrome, and the probable drug could be chloramphenicol. Okay. So like signal detection, over the years we've been seeing question papers, and the high yield areas that are asked frequently in general pharmacology is regarding pharmacokinetic principles, pharmacodynamics, clinical trials. Now recently with curriculum implementation with new syllabus that has been revised, so you have ADR monitoring and pharmacovigilance related questions, and application wise you can have acts, schedules and calculations based on loading dose, maintenance dose, creatinine clearance and so on. Okay. And expected additions is your cal, Okay, computer-assisted learning, we have experiments on animals that are shown as software or computer-based learning. So those could be asked, concepts regarding that could be asked. Antibiotic policy, pharmacovigilance, and with COVID situation, we've been doing vaccination and everything. So your adverse effects or adverse events following immunization could be asked. Okay, so just have a quick view of all these if time permits. Okay, so I think that's all for today. Hopefully it went fine, well. So thank you.
Yeah, thanks, Dr. Divya. It was an excellent session. It covered all the basics, high yield concepts, and in a short span of time, it will be very useful for the NEETPG aspirants. And we'll wait for a few minutes to clarify any doubts from the students. No doubts, we'll end in a couple of minutes.
Okay, sir.
So I think there are no doubts from the students' end. So class, with crystal clear class. So shall we end?
Sure, sir.
Yeah. Thank you, Dr. Divya.
Thank you, sir. Thank you, everyone.